Hello, this is Dr. Ajinkya. Today I'm going to be teaching you guys a rather new concept from the radiological aspect, as in how you can read a dynamic CT scan. Now, by the word dynamic CT scan, I mean the CT scan is in motion, where the anterior most aspect to the posterior most aspect of the sinus and the skull base anatomy, you can have a complete look with the help of a software. As you can see on my screen, I'm using a software called as Radiant DICOM for Windows 10. Now, what happens basically is that you have a DVD which contains preloaded CT MRI images of the patient in various different views. You just have to open the software, load the DVD, and there you have. As you can see onto the left of my screen are various sections of the patient in different views. So I'll choose to start off with the coronal section. Now, as I always say, when the surgeon is operating, he operates in a coronal view. So to read the CT scan in a coronal view first is of utmost importance. The second thing I need to tell you guys is that the thickness of the scans, whenever you asked a radiologist to give you a CT or MRI, it normally should range from 0.6 to 1 mm. It normally should range from 0.6 to 1 mm because various neurovascular structures, say for example the anterior ethmoidal artery has a diameter of 0.8 to 0.9 mm roughly. So if you order a scan which ranges from above 3 to 5 mm in cut sections, you are bound to miss the anterior ethmoidal artery, which can be a difficulty for the surgeon if he ends up doing a skull base surgery or the ethmoidal surgery high up towards the skull base. So it's very important, first thing, to order a scan of minimum 0.5 to maximum 1 mm thickness, not more than that. The second thing is the DVD should contain all the sections, that is 3 of them, axial, coronal and the sagittal, because various certain views are typical for certain types of anatomy. For example, if you want to view the orbital anatomy, the lamina papyracea anatomy, it is best viewed in the axial. If you want to learn about the frontal ethmoid cells, the frontal recess and the entire frontal anatomy, the sagittal view is of utmost importance. So let's begin with the reading of a dynamic CT scan, where I'll be showing you how the CT scan is in motion, and exactly from the very anterior most aspect of the patient's CT scan to the posterior most aspect of the patient's skull base, you can actually view each and every surgical anatomy on the CT scan. Now, to begin with, I'll just give you a gist. In this software, you can zoom in and zoom out the patient's bony anatomy. It also contains various settings where you can change to a soft tissue window or to a bony window. I'll just show you. Now, I'm going towards the now. This is complete bone window. As you can see, you can visualize only the bony part, and as you scroll down, it will concentrate more on the soft tissues as well. So as you can see, this is pure bony window. See, as you can see, this is pure bony window, and this becomes a soft tissue window now. So this is pretty good for the surgeon to have a better idea or better anatomical study. So to begin with, I'll start off from the very anterior most aspect of the CT scan. Now, this CT scan is a 1 mm CT scan. As you can see here, this is a coronal view, bone 1.0, which is a 1 mm CT scan. Okay, so to begin with, you can see a coronal view over here, and this is the frontal skin, the skin of the forehead. This is the nasal ala on both the sides. As you go behind, you can see this white structure coming off. This is the frontal bone area, and this is the area of the nasal bone, the right and the left one. This is being the nasal ala. As you keep on going behind, what you can see over here is actually the frontal lobe of the brain, and below that you can see this is the right and this is the left frontal sinus. This is the nasal bone. Here you can clearly see that these two nasal bones are in picture. This is the right one. Let me just zoom in this picture. As you can see here, this is the left nasal bone, this is the right nasal bone with the internasal bone suture, this being the frontal nasal process of the maxilla, this being the perpendicular plate of the ethmoid bone, which forms the bony part of the nasal septum, and this being the vertical nasal cartilage, the cartilaginous septum. And as you can see, this being the right frontal sinus and this is the left frontal sinus. This is the frontal lobe of the brain over here. So as you keep on going behind, you can see the frontonasal process of maxilla, the perpendicular plate of the ethmoid, the right frontal, the left frontal. Now both of these frontal sinuses are almost completely opacified. As you can see on the left side, it's completely opacified, having a hyperdense collection. The right side of the frontal sinus is also collected, having a hyperdense collection with air shadow in between. So as you go behind, you are continuously scrolling down to see the change in the anatomy, which is live in motion. So here in this sections, you are not skipping out or you are not missing out on any of the anatomy, as you are going in a continuous motion from anterior to the posterior aspect. So basically I'll be clearing you the anatomy of individual areas step by step. So to start with, I'll teach you the anatomy of the nasal bone and the formation of the frontonasal process of the maxilla. So if you can see from the very anterior aspect, we could only see the two nasal bones. Now as we are going behind, you can see the CT scan is in motion and how these two nasal bones are fused to each other with the internasal bone suture, and how now the nasal process of the maxilla is coming into picture with the perpendicular plate of the ethmoid. And as you can see, the frontonasal process of the maxilla becoming elongated in picture. So as you can see here, right from here, so you can have a better picture of the nasal bones and the frontal nasal process of maxilla. Similarly, I will show you the frontal sinus. Now this was the most anterior aspect. You can see slowly the frontal sinus on the left coming into picture, and then the right. Now so far, as I always say, the point up till which the frontal floor is intact, you can see here, this is the frontal floor, this is the frontal floor. Till the point the frontal floor is intact, it is still the frontal sinus. Now as you can see in motion, if I go behind slowly, this is the area where the frontal sinus floor disappears. So this officially marks the beginning of the frontal recess area. So if you have a CT scan in motion, you can exactly pinpoint the anatomy of the frontal sinus, the frontal recess. Now the frontal sinus lies anterior to the frontal recess and the frontal sinus drains posteriorly. With the help of this dynamic CT scan, what we can pinpoint is the exact anatomy of the drainage of the frontal sinus. Now as you can see over here, this is the left frontal sinus. Now if you keep the left frontal sinus in view, I go back slowly. Now the frontal floor disappears and now the frontal recess has started. See this? The entire frontal recess anatomy is clearly picturized. If you can keep on going behind, this area is the entire area of the frontal recess over here. Yeah, so any pathology which is affecting the drainage of the frontal recess can be studied in detail with the help of this dynamic CT scan. So This is the frontal floor. This is also called as the frontal beak. As we all know, the frontal beak forms the anterior wall and the floor of the sinus. So the point up till which there is presence of frontal beak, that is, the floor is present, it is the frontal sinus. The moment the floor disappears, as in this case over here bilaterally, starts the frontal recess, and this is the area where the frontal sinus drains into. Now, as you can see, the left frontal sinus is completely opacified, and the right frontal sinus is having mild to moderate minimal collection with an area of proper pneumatization in between. So that was the anatomy of the frontal sinus and the frontal recess beginning, the anatomy of the nasal bone and the frontal process of the maxilla. So as we go behind this, you can see over here, this is the Crista Galli, which is a part of the ethmoidal labyrinth, the anterior cribriform plate. So if we go from the most anterior aspect, as you can see over here, this was the frontal sinus, the left one, the right one, with the interfrontal sinus septa, the nasal bone over here, the frontonasal process of maxilla, the frontal beak. As you go behind, we could see the frontal recess area. Now, the cribriform plate, or you can say the anterior cribriform plate, or the anterior ethmoidal roof, is roughly 0.5 to 1 centimeter behind the frontal sinus. So once the frontal recess area starts, which is the end of the frontal sinus, if you go posteriorly, you can see this structure coming up right now over here. This is the Crista Galli. The Crista Galli is an upward diamond-shaped projection of the anterior ethmoidal labyrinth, to which the falx cerebri over here is attached. Now, you can see this cribriform plate. This is the cribriform plate over here, the anterior cribriform plate with the Crista Galli in the center, and this is the midline septum all over. You can see a minimal spur in the lower aspect. Now, so you can see the entire cribriform plate appearing right up to the posterior ethmoidal roof, right around here. So you can study the entire anatomy of the cribriform plate along with the Crista Galli, right from its anterior aspect to the posterior aspect. So we saw the frontal sinus for the frontal recess, the start of the cribriform plate roughly 0.5 to 1 centimeter behind the frontal sinus, and we could see the cribriform plate over here. Now this was the very beginning of the cribriform right here, and here we can see the appearance of the middle turbinate. Okay, so when we are studying the anatomy of the middle turbinate, we all know there are three parts to the middle turbinate, which is the anterior, posterior, and the middle 1/3. Now, with the help of a dynamic CT scan, you can go right from the anterior aspect of the middle turbinate right up to its posterior attachment without skipping any image in between. So what we see here is this is the midline septum, and on either side of the septum, whatever you see here. Now let's go from the very start over here. Now here you see the very beginning of the middle turbinate over here. That's the middle turbinate. That's the middle turbinate bone actually. So that's the anterior 1/3 of the middle turbinate being attached to the junction of the medial and the lateral lamella of the cribriform. Now let me just zoom in for you guys. Now as you can see, this is a Crista Galli, and this was the middle turbinate bone. Now this is the cribriform plate medial lamella, which is the horizontal segment, and this is the vertical segment called as the lateral lamella of the cribriform. Now the junction of these two, that is the medial and the lateral lamellar junction, is the attachment of the vertical part, or you can say the anterior 1/3 of the middle turbinate, which lies in the sagittal section. So if I go from the now this is the most anterior aspect of the cribriform. Yeah, right here. This is the most anterior aspect where the middle turbinate just appears. Now this is the area where the middle turbinate has just started to appear, this area. So this is the junction of the medial and the lateral lamella, and as you can go behind, you can see the entire middle turbinate coming into picture. Now the anterior 1/3 is followed by the middle 1/3. Now the middle 1/3 is also called as the ground lamella. Okay, the middle 1/3 is the ground lamella, which has attachment to the lamina papyracea. Now this was still the anterior 1/3. Now why this dynamic CT scan is so important? You can pinpoint the exact location where the middle 1/3 of the ground lamella is going to attach. Now as you can see, as you keep on going posteriorly, you can see this middle turbinate taking a slight bend towards the lateral aspect. You can see over here as well. Okay, you can see this. Now previously it was attached to the junction of the cribriform. See this vertical structure? That's the middle turbinate, anterior 1/3. Now as you go behind, as you are going behind, you can see this is still attached. Now as you keep on going behind, the attachment gets cut off here. Okay, and slowly you see this structure coming up here, this structure coming up, that is going towards the lamina papyracea. See here? Now this middle turbinate is no longer attached to the cribriform plate, but there's a huge gap in between, and it is taking a lateral course now. I'll just zoom in for you guys. You can see this, that's the middle turbinate over here, giving a lateral attachment to where? This is the lamina papyracea, the medial wall of the orbit. Same thing on the left side. You see this is the middle turbinate. This is a huge gap in between. Now this is no longer attached to the cribriform, but taking a lateral bend towards the lamina papyracea, as you can see over here. So this structure is the ground lamella, or the middle 1/3 of the middle turbinate. So if you further keep on going posteriorly, you can see, so if you keep on going posteriorly, you can see the same middle 1/3 now not having an attachment to the lamina, but bending more further posteriorly. See this? That's the middle turbinate. So, and what is this? This is the medial, this is the lateral aspect. This is the perpendicular plate of the palatine bone. This is the palate. You can see this is the palatine bone. This is the vertical process of the perpendicular plate of the palatine bone, and this is the horizontal plate of the palatine bone, forming the hard palate. So you can see this is the middle turbinate. This is the middle turbinate on both the sides, and this is attached to where now? This is the posterior most 1/3 of the middle turbinate attached to the perpendicular plate of the palatine bone over here, right here. So if I go behind and I show you guys right from the anterior aspect, as you can see over here, this was the very beginning of the cribriform plate with the Crista Galli coming into picture, and this is a very anterior most aspect of the middle turbinate, the anterior 1/3, having an attachment to the cribriform plate. As you keep going behind, you can see this middle turbinate to be attached to the lamina right now. Now I see this is the lamina papyracea attachment of the middle 1/3. That is the ground lamella or the basal lamella, which gives the middle turbinate its stability. So if you keep on going further posteriorly, the same structure is now no longer attached to the lamina papyracea, as you can see over here. Now see this, now it's getting a bend, it is turning laterally to attach to where exactly? As you can see this is the middle turbinate, posterior 1/3 over here. This is attached to the perpendicular plate of the palatine bone. So nowhere in between you have skipped any area. So you had a proper motion view of the entire middle turbinate. So this is very important, where a surgeon needs to know where the middle turbinate exactly attaches to, or what the variations are, what the anatomical variations could be in the surgery, so to have a safe and a surgery without a complication. So this was the middle turbinate for you guys, and as we could see right from the anterior most aspect, so that was the frontal sinus, so the frontal recess, the middle turbinate origin, the three parts of the middle turbinate. Now We all know the very important structure which we always come across is the nasolacrimal duct. Now, right from the anterior aspect, what we see, the first thing is the frontal sinus, the left being completely opacified. So that's the right, the left. This is the frontal beak on both the sides. This is the nasal bone, the most posterior aspect. This is the frontonasal process of the maxilla. Now, two things very important over here right now. You just have to follow the frontonasal process of the maxilla. Now, as you keep on following it posteriorly, just keep on following the frontonasal process of the maxilla posteriorly, and the very first cell which you see is the agar nasi cell. Okay, so the very first cell which you see is the agar nasi, and as I can see here, see, this is the frontonasal process of the maxilla right here. Okay, you keep on following it posteriorly, you see something coming up over here. This is also opacified, having a dense collection within. So as you keep on coming, following the nasolacrimal, following the frontonasal process of the maxilla over here, I can see the very first pneumatization starting to appear. This cell over here, that is called as the agar nasi cell. As you can see on this side and this side, both the sides agar nasi are opacified. So the first thing you look for is the agar nasi cell by following the frontonasal process of the maxilla. As in this case, we can see this is a very appearance of the agar nasi, which is opacified. Now, agar nasi, what is the importance of agar nasi? First of all, what is agar nasi? Agar nasi is the anterior most ethmoidal cell which is pneumatizing the lacrimal bone. Now, what is the significance of this agar nasi? If the agar nasi is a huge cell, in case where the pneumatization is very huge, the lacrimal bone is gonna be very huge and pressing upon the nasolacrimal duct system. So whenever you are performing a DCR operation endoscopically, you need to break open the agar nasi cell so as to have a proper exposure to the nasolacrimal duct system area. So that was the first thing for the agar nasi. And the second most important thing is that, as we all know, the agar nasi cell is the anterior boundary of the frontal recess area. So if there's a huge agar nasi cell, as you can see, this is the agar nasi, which is having a hyperdense collection over here. So it could block the frontal recess from the anterior aspect, giving rise to frontal blockage or the blockage to the frontal outflow, wherein could cause frontal sinusitis on a long course. So that's the two important things why we should take into consideration the agar nasi, was, as I just explained, for the DCR part and for the frontal drainage output part. See, as I follow it from the anterior, this is a frontonasal process of the maxilla. So far, no pneumatization yet. As I keep on going behind, I can see a cell coming here. See this area? See this area? I can see a cell popping up. This is the agar nasi cell, and which is completely opacified on both the sides. And this is a frontal recess area still. As I mentioned earlier, this is the frontal recess area, and this was the agar nasi bounding it anteriorly. Okay, so if you keep on going behind, this agar nasi cell disappears, and what appears is the bulla ethmoidalis, which is right here. The cell you can see over here right now, a huge cell, that's the bulla ethmoidalis. So this cell area over here, you can see the huge cell area. This area belongs to the bulla ethmoidalis area. So the frontal recess is anteriorly bounded by the agar nasi, and posteriorly it is bounded by the bulla ethmoidalis. So if there's a huge agar nasi, the frontal recess could get blocked anteriorly, or if there is a suprabullar cell or excess pneumatization of the bulla ethmoidalis, the frontal recess could get blocked from the posterior aspect. So the frontal recess lies in between these two. As you could see here, the frontal recess lies between these two cells over here. That's the area of the frontal recess. Behind, if you go behind, you can see this bulla ethmoidalis coming right here. So the anatomy should be well studied. Now, the third most important thing is the nasolacrimal duct system. Now, if I go from the anterior most aspect, just keep following the nasolacrimal, the frontonasal process of the maxilla. As you can see, this is the frontonasal process of the maxilla. If I keep on going posteriorly, I could see the agar nasal cell over here, and just anterior to the agar nasal cell, lateral to the bony part over here, this is the lateral aspect, you can see the nasolacrimal duct system on both the sides. Now, this case is a tilted scan, so the patient on the right side is more prominent as compared to the left side, because the patient is tilted to the left side, so the structures on the right side appearing first in the scan. So there's a slight shift or tilt, you can say, towards the left side. See, if I go from the anterior aspect, this is the frontonasal process of the maxilla. If I go on posterior, if I keep on going posterior, there I could see the agar nasal cell popping up, and just anterior to the agar nasal cell lies the nasolacrimal duct system. This is the nasolacrimal duct system, this vertical soft tissue you can see over here. This is the nasolacrimal duct system over here. Now, if this is the nasolacrimal duct system, so the agar nasi and the nasolacrimal duct system are in close relation to each other. So the one thing I want to show you in this dynamic CT scan is that you can trace the entire pathway, the opening of the nasolacrimal duct within the inferior meatus through the Hasner's valve. Now, it's a common fact that the nasolacrimal duct continues into the inferior meatus via the Hasner's valve. There's a valve called as the Hasner's, so it opens through the Hasner's valve in the inferior meatus and drains into the nasal cavity. So just follow my cursor over here. This is the nasolacrimal duct system, the right side. As I keep on going posteriorly, see this, follow this area, follow this area, follow this area. See the nasolacrimal duct going down, and then finally opening up into the inferior meatus. See how easily we could follow the nasolacrimal duct system. I'll show it to you one more time. So this was the very start of the nasolacrimal duct system. Once you see the agar nasi, you see the nasolacrimal duct system over here. See, this is a proper nasolacrimal duct, the sac over here, and the duct starting from. Now just keep on following this nasolacrimal duct system. You can see it following down, and then opening up into the inferior meatus over here through the Hasner's valve. So this concept of using a dynamic CT scan is very important to know the anatomy, or what could the block be. If the patient has purulent discharge from the nasolacrimal duct system, you could act physical anatomical obstruction at what level it could be. So this is basically a 3D anatomy in motion of the CT scan you can get. So we covered so far the frontal sinus in the recess area, the agar nasi, the frontonasal process of maxilla, the entire nasolacrimal duct system you could see. The same thing I can show you on the left side as well. If you keep on following, this was the nasolacrimal duct on the left side. Keep on following it. See this is a nasolacrimal duct coming down and then finally opening to the inferior meatus. See this, that's the Hasner's valve opening near this area. So you can easily trace the entire nasolacrimal duct system. So moving forward, we should know the anatomy of the osteomeatal complex. Now, as a fist surgeon, as a sinus surgeon, the surgeon should be knowing the anatomy thoroughly. Now, when a patient is coming to your OPD with a complaint of facial tenderness, repeated nasal blocks, and you do a clinical examination where there is positive tenderness on palpation over the maxillary antrum area, and when you get a CT scan done after a maximal medical therapy of steroids, and you can see that there is the osteomeatal complex over here in this region, and the osteomeatal complex outflow is blocked. So before diagnosing it, you should know the anatomy of the osteomeatal complex. Now, what is osteomeatal complex, or the OMC basically? Now, as you can see on the left side over here, this is the inferior turbinate. You can see this was the middle turbinate, the anterior 1/3 part. This is the anterior 1/3 attached to the cribriform. This is the inferior turbinate. The superior turbinate is nowhere in the picture right now because we are still in the anterior ethmoidal cavity. Superior turbinate is a part of the posterior ethmoids, so we cannot visualize the superior turbinate over here. I'll show you in some time where the superior turbinate is exactly lying. So this is the middle turbinate, anterior 1/3 attached to the cribriform right here. This is the inferior turbinate, the inferior turbinate bone. This area becomes the septum area with a little spur on the left side. This is the middle meatus area. This is the inferior meatus area. This is the maxillary sinus, as you can see on both sides. Both the maxillary sinus being completely opacified with a bit of pneumatization in between. Could be a sign of an anaerobic infection, secondary infection. So as you can see, this is the inferior turbinate bone. Now you can see this white structure coming as a vertical aspect over here. You can see this is a white structure. Now that is the uncinate process bone. Now that is the uncinate process. Now I can show you a bit more prominent. We will be giving you a bone window. Now this is a bony window. Now as you can see, this was the maxillary sinus area. This was the inferior turbinate bone. This is a medial maxillary wall, the maxillary sinus floor, the anterior lateral wall. Okay, so this bone, which you can see arising from this bone, you can see arising from the inferior turbinate. This is the uncinate process. Okay, this is the uncinate process. So this is the uncinate process. Now the uncinate process has two parts. That is one, the horizontal, as you can see here. This is the horizontal process of the uncinate, and this is the vertical process of the uncinate. Now the vertical portion of the uncinate is variable in its attachment. Normally about 90 to 95% of its attachment is on the lamina papyracea. So if I just follow it from the anterior to the posterior aspect, just keep on following the uncinate, you can see the uncinate. See over here, I'll show you one more time. You can see this was the beginning of the uncinate process. The middle turbinate, inferior turbinate, this is the uncinate. So the very beginning of the uncinate process, this is a horizontal and this is a vertical part. If I'm going behind, as I'm going behind, just keep on following the uncinate. You can see this is the uncinate having an attachment to the lamina papyracea. See, in cases of 95% of the population, the uncinate process is going to attach to the lamina papyracea. Now, but before attaching to the lamina papyracea over here, the uncinate process first has to pass medially to merge with the medial wall of the agar nasi. See, as you can see, I showed you the agar nasi before. As you can see over here, this was the agar nasi. Wait, this was a nasolacrimal duct system. This was the appearance of the agar nasi area over here. This was the agar nasi appearance. So this is the vertical process of the uncinate. It travels up, it merges with the medial wall of the agar nasi, and then it turns laterally to attach to the lamina papyracea over here. You can see that it is going medially to the agar nasi, and then it goes lateral to attach to the agar nasi, attach to the lamina papyracea. So depending upon the attachment of the uncinate process over here, it decides the course of the frontal sinus drainage. Now as you can see, this is the uncinate process being attached laterally to the lamina papyracea. In this case, the frontal recess will drain into the middle meatus. The drainage will be medial. If it's simple logic, if the uncinate attaches laterally, the drainage of the frontal sinus will be medial. So attachment is lateral, drainage is medial. So this is draining into the middle meatus area. Had this attachment been towards the middle turbinate over here, see, just follow my cursor. If this attachment was not here, instead of that, it would have been here on the middle turbinate or on the cribriform somewhere over here. Due to excess pneumatization of the agar nasi somewhere here, it, instead of being attached to the lamina, which you normally see, it would attach to either the cribriform plate, that is the skull base, or the middle turbinate over here. So in that case, what you do is you have to read the CT scan in detail. So in that case, the frontal sinus drainage will be lateral. Simple logic again. If the attachment is medial, the drainage will be lateral. So it will drain directly into the infundibulum right here. So in that case, the maxilla and the frontal will drain common pathway. So if something gets blocked, they both get blocked. So this is the medial and the lateral drainage explained on a dynamic CT scan. So in this case, it is following a normal condition, which is the lamina papyracea. Now, there's one more thing which a lot of junior MS surgeons are not aware of, is the term called as the recesses terminalis. Now, what exactly is this recesses terminalis? Now, in this case, as you can see, this is the uncinate process being fused with the lamina, having first a medial course and then the lateral course. So when the uncinate has this medial and lateral course, first medial and then lateral, it forms a small blind area over here. Like this it follows. So it forms a small blind area over here called as the recesses terminalis. This, you can see this small pocket over here. So this is the uncinate, first going medially and then laterally to the lamina papyracea. So this area over here, you can see, is a blind pocket. So this is called as a recesses terminalis. Okay, so remember that. Okay, so we got the anatomy of the uncinate. So as we followed the uncinate, now the next thing is to this is the inferior turbinate, the middle turbinate, the uncinate process. The second part of the OMC is the bulla ethmoidalis. Now, posterior to the uncinate is the bulla ethmoidalis. As you can see on this scan, this is the bulla ethmoidalis. This is the bulla ethmoidalis appearing on the left now. As I said, the right will appear first because this is a tilted scan. So the right structures will appear first and the left will appear later. So I will explain you on this right side. This was the uncinate process over here. Now, very beginning of the uncinate process, I'll show you on the right side. This is the inferior turbinate. This is the uncinate process. As you keep on going behind, you can see now the uncinate on the right side is having a different course over here. This is the uncinate on the right side. It is getting fused. It's not quite visible on the right side though. It is either getting fused to the middle turbinate. The upper part is not visible on the scan because of the excess collection. Maybe in the bony window you can see. So this was the uncinate, and as we are going forward from anterior to posterior, see, we cannot see the upper part of the uncinate process over here. Maybe it could be it could have become polypoidal in nature, so that it has lost the bony anatomy. So yeah, it is very common for the uncinate to become polypoidal and the bony having the bone going under a lot of changes, getting a lot of thinned out. So yeah, it is expected because of the pressure effect from the polyps externally. Okay, so yeah, so the uncinate process was dealt with. Now you just have to follow the bulla ethmoidalis. So this is the case. This is the area of the beginning of the bulla ethmoidalis. Now, one thing which you have to always remember, that the bulla ethmoidalis always has its lateral attachment on the lamina papyracea. So whenever you are removing the bulla ethmoidalis, make sure you don't give a tight pull, otherwise it could break off the lamina papyracea if you are too hazy in removing that. As you can see, this is the entire bulla ethmoidalis. This is the uncinate process, and this is the maxillary sinus that drains through this small recess area called as the hiatus semilunaris inferioris. I'll show you on this side. See this? This is the uncinate process, and this is the bulla ethmoidalis region. As you can see over here, this area between the bulla ethmoidalis and the uncinate process, this small area you can see, this is the area of bulla ethmoidalis, this is the area of the uncinate, and you can see a small slit-like area between them that is called as the hiatus semilunaris inferioris, which is a two-dimensional space, drains into the maxillary sinus through the infundibulum. This area you can see, this is the hiatus semilunaris inferioris, and this area which you can see over here is a three-dimensional space called as the infundibulum, which opens up into the maxillary sinus over here. So as you can follow on the CT scan, you can see that this is the most anterior aspect of the maxilla. This is the maxilla, the most anterior aspect. This being the nasolacrimal duct opening into the inferior meatus, the maxilla becoming more widened up. This is the hiatus semilunaris inferioris, this is the infundibulum, and this is the sinus proper. If you keep on going posteriorly, you can see the entire area of the outflow is blocked, and as a result of the stasis, there is a lot of retention in the sinus. So this is the area of the bulla ethmoidalis. So this is the bulla ethmoidalis, the posterior most aspect, and as you can see over here, this is the middle turbinate starting to go laterally towards the lamina papyracea attachment. So this is the ground lamella. Now, the most important thing, the bulla ethmoidalis posteriorly is the ground lamella. See, this was the beginning of the bulla ethmoidalis, and immediately behind the bulla ethmoidalis we could see this attachment towards the lamina papyracea right here. So that was the ground lamella. So if we go from the anterior to the posterior aspect, the most anterior aspect, the structure is the uncinate process. After the uncinate, posteriorly comes the bulla ethmoidalis. Between them is the hiatus semilunaris inferioris. If we go further posterior, behind the bulla ethmoidalis lies the ground lamella, as I just showed you over here. Now this ground lamella, and between the bulla ethmoidalis and the ground lamella is a space. There's always a space which is called as the retrobullar recess. Okay, so there's a retrobullar recess, and if the bulla is not attached to the skull base sometimes, as you can see, this is a bulla ethmoidalis over here. This was a huge bulla ethmoidalis over here, going right up to the skull base over here. See, this is a skull base over here, and this was a bulla ethmoidalis. So there we can see a small gap over here. As you can see, there's a small gap over here in this region. See, this is a bulla ethmoidalis, and this is the area of the bulla ethmoidalis. Now, most anteriorly, it is attached to the skull base. So basically, the area posterior to it is the area of the anterior ethmoidal artery. So if in sometimes the bulla is not attached to the skull base, it forms a small space called as a suprabullar recess, and if there is a retrobullar recess and a suprabullar recess together, they commonly drain into the middle meatus medially, just lateral to the middle turbinate in this area, and that area becomes the hiatus semilunaris superioris. Now this was the area, as we all saw, this was the area of the uncinate, the bulla ethmoidalis. This was the area of the hiatus semilunaris inferioris. Okay, this was the area of the hiatus semilunaris inferioris, and this area, if there's a suprabullar recess over here, and this is the retrobullar recess, so this area drains commonly lateral to the middle turbinate over here in this region. This is called as the sinus lateralis of Grunwald. Okay, so that is called as a Grunwald sinus, also called as a sinus lateralis. So these basic things you should know when you are operating on the patient on an OMC area. It makes your life much easier. So this was basically the osteomeatal complex for you guys, and as we all know, the ground lamella divides the anterior ethmoids from the posterior ethmoids. Now see, as I said, this was the attachment of the middle turbinate to the cribriform plate, and as you go behind, you could see this middle turbinate having a lateral turn. This was the area of the ground lamella. Now immediately behind this, as I go posteriorly, see, I'm going posteriorly, immediately the area where the ground lamella ends starts the posterior ethmoids, marks the beginning of the posterior ethmoids. Now this entire thing is the area of the posterior ethmoids, and now we will be able to see the superior turbinate. Now from the most anterior aspect, I'll show you. Now see, this was the area where the middle turbinate was attached to the cribriform. This is the cribriform attachment. Now as you go behind, as you can see, this is going laterally towards the lamina, and there's a clear gap in this area. See, it's no longer the middle turbinate, anterior 1/3, but the middle turbinate is middle 1/3. And what structure is this now? This is the official beginning of the posterior ethmoidal cavity. So this is the superior turbinate right here. This was the ground lamella. This is the superior turbinate. As I go behind, you can see this is the end of the ground lamella. This is the superior turbinate, and this entire region is the area of the posterior ethmoids, which is fully opacified, having collection all together. If you keep on going posteriorly, this will be the posterior most aspect of the posterior ethmoidal cells, and you can see the middle turbinate having an attachment to the perpendicular plate of the Palatine bone, denoting the posterior most aspect of the middle turbinate. And you can see this is the superior turbinate clearly over here. That's the superior turbinate, which minimal collection over here. Okay, so you should know basically where the anterior ethmoids end and where the posterior ethmoids begin. There's also one more important thing in the anterior ethmoids is the anterior ethmoidal artery. Now this, for a fess surgeon, for a skull base surgeon, this artery is of utmost value, because this artery has a lot of significance. Now many young surgeons, when they open up the frontal sinus, they fear of opening the skull base, the lamina, and the most important, the anterior ethmoidal artery. Now what is this anterior ethmoidal artery basically? I'll just give you a small gist of it. Now from the most anterior aspect, now whenever you are trying to identify the anterior ethmoidal artery on a CT scan, you always make sure that the anterior ethmoidal artery runs in a bony canal from the orbit to the cranium, called as the orbitocranial canal, through which it runs along with the anterior ethmoidal nerve and the anterior ethmoidal nerve. Okay, so the anterior ethmoidal artery runs along with the anterior ethmoidal vein and the anterior ethmoidal nerve. The anterior ethmoidal nerve being a continuation of the nasociliary nerve from the orbit. So always remember that the anterior ethmoidal artery is a branch of the ophthalmic artery, ophthalmic artery being a branch of the internal carotid artery. Now we are in the most anterior aspect. You can see this is a cribriform plate. This is the Crista Galli. This is the middle turbinate 1/3, anterior 1/3. Now there are 4 points on how you can identify the anterior ethmoidal artery. 4 basic points. The very first point is by the orbital muscular anatomy. Now as you can follow the orbit over here from the most anterior aspect, as they go behind, now you can see the muscles coming into picture. These are the orbital muscles. Now if I give you a better soft tissue window, see, this is a soft tissue window now. So if I give you a better picture, these are the muscles of the orbit. Okay, so this is the muscle of the orbital nature. Now you keep on following it posteriorly. Now this is the superior rectus, medial rectus, inferior rectus, lateral rectus, and this small area over here is the superior oblique muscle, and this in the center is the optic nerve. This is the optic nerve. See, this is a medial recti and this is the superior oblique muscle. Now as you keep on going behind, these two, as you can see in the anterior aspect, these two muscles are having a huge gap in between, but as you keep on going posteriorly, they almost touch each other. That is called as the confluence of these muscles. You see this? You see this? There's hardly any gap in between. Now when these two muscles, they almost come close to each other, you can see this is the orbital beaking over here. This is called as the orbital beaking at the confluence of these two muscles. Now see this structure coming out. See this structure coming out? That is the anterior ethmoidal artery. See, that's the anterior ethmoidal artery, the posterior aspect, and see, this is the anterior ethmoidal artery proper. Now to visualize the artery, see, this is the anterior ethmoidal artery, this is the orbit, and this is a cribriform. It is entering from the orbit to the cribriform, that is the orbitocranial canal. So whenever you follow the muscular anatomy, you can easily visualize the anterior ethmoidal artery. Now there are three more other factors where you can identify it. The very first being the ground lamella. The ground lamella is the most consistent landmark for finding the anterior ethmoidal artery. Now as I showed you earlier, this was the middle turbinate anterior 1/3. Now if you keep on going posterior, this is the lateral bend denoting the beginning of the ground lamella. Now this was the proper ground lamella. This was now then the attachment to the perpendicular plate of the palatine. So you see this is the artery. You see this is the anterior cranial fossa. Now remember, you can get always confused between the anterior ethmoidal artery and the posterior ethmoidal artery. So always remember where the anterior ethmoidal artery could be and where the posterior ethmoidal artery could be. For that, as I always say, the most consistent is the ground lamella. Now this was the anterior 1/3 of the middle turbinate. Now as you can see, the middle turbinate going and having a lateral attachment over here. See this is a lateral attachment. So this is the posterior most aspect of the ground lamella. Now anterior ethmoidal artery is always either few or immediately anterior to the ground lamella. So this was the anterior most aspect. Now see this turn. This is the most anterior aspect of the ground lamella over here. As you can see over here, this is the anterior 1/3. As you can see right here, this is the very beginning of the ground lamella. So from this point, if I come anterior, a few anterior to the ground lamella, I can see the anterior ethmoidal artery right here. You can see this is the anterior ethmoidal artery. This is the orbital beaking happening over here. This is the orbital beaking. Sometime back when I showed you, it was a posterior ethmoidal artery over here. You see this? This is a posterior ethmoidal artery. So this is how easily a junior ENT surgeon or a new surgeon who is new into the CT scan era and the FES era could get easily confused between the two arteries. So the artery which you can see over here is a posterior ethmoidal artery, and if you keep coming anterior, this is the anterior ethmoidal artery. You see that? So this is the anterior ethmoidal artery, which is few anterior to the ground lamella, and as I showed you the confluence of the muscles over here, you can see this is the medial recti and this is the superior oblique. When they come close to each other, it forms a beaking of the orbit. You see this beaking of the orbit? This is the orbit and this is the medial lamella and this is the lateral lamella of the cribriform. So it enters into the lateral cribriform plate from the orbit. This is called as the orbitocranial canal, and this canal consists of the anterior ethmoidal vein, the nerve and the artery. So this is how easily you can identify the anterior ethmoidal artery lying in the anterior ethmoidal cranial fossa. Now, once you enter into the posterior ethmoidal cavity, which is first you have to denote the ground lamella. If you go posterior to the ground lamella, immediately posterior to the ground lamella, or somewhere in the skull base in the posterior ethmoids, there will be the posterior ethmoidal artery. Now, this I just show you the posterior ethmoids. See this area over here, just at the level of the skull base is the opening of the posterior ethmoidal artery. You can see this beaking happening over here. That's the posterior ethmoidal artery. Now, there are a few differences between the anterior ethmoidal artery and the posterior ethmoidal artery. Anterior ethmoidal artery, as I showed you earlier, this was the anterior ethmoidal artery. See this proper beaking of the anterior ethmoidal artery, which is anterior to the ground lamella and near the confluence of the superior oblique and the medial recti muscle. Now, see this is the skull base over here, the sloping skull base in the anterior aspect. This is the lateral lamella, this is the medial lamella, the vertical lateral and the horizontal medial lamella breaking the lateral lamella. See, always the anterior ethmoidal artery will run at a lower level as compared to the skull base. There will be always a distance of few millimeters between the anterior ethmoidal artery and the skull base. As you can see over here, this is the area of the skull base, and this is the area, few area between the skull base and the artery. Now, if you see the posterior ethmoidal artery over here, see this is the posterior ethmoidal artery, that is base. It will never hang in the posterior ethmoidal cavity because the posterior ethmoidal skull base is thicker as compared to the anterior skull base. So this posterior ethmoidal artery runs at a higher level and it is almost always running within the skull base bone. It rarely hangs in the canal. So this is how easily also you can identify which is the anterior and which is the posterior ethmoidal artery. So the muscular anatomy, the ground lamella being the second, the third is the supraorbital cell. Now, I'll show you the most anterior aspect. Now, this patient has a supraorbital cell mostly towards the left side. As you can see, this was the area of the frontal sinus. This was the area of the frontal sinus. As we go behind, this is the area of the frontal recess. And this is the area where the maxillary sinus is starting. See, once the maxillary sinus starts, and you can still see a structure like frontal sinus, it cannot be frontal sinus. It has to be a supraorbital cell. You can see this is the orbit and this is above the orbit. So this is a supraorbital cell which is also completely opacified. So this is a supraorbital cell. Now, the anterior ethmoidal artery will lie immediately caudal to the supraorbital cell. Now, just follow the supraorbital cell over here. You see this? This is the beaking of the anterior ethmoidal artery. And what was this? This was the beginning of the supraorbital cell. This is a supraorbital cell draining into the frontal recess and eventually the supraorbital recess. Now, as we go posteriorly, you can see the supraorbital recess is ending and immediately caudal to it is what? This is the anterior ethmoidal artery. Immediately caudal to it. Caudal by I mean it is posterior to it. So the moment the supraorbital cell ends, immediately posterior to it is the anterior ethmoidal artery, as you can see right here. So first the muscular anatomy, second is the most consistent being the ground lamella, few anterior to the ground lamella and immediately posterior to the supraorbital cell. So always remember, it is anterior to the ground lamella and posterior immediately to the supraorbital cell. Okay, and the third is the fourth point is the bulla ethmoidalis. Now, as we could see over here, you can see this area. This is the bulla ethmoidalis. This is the uncinate process. This is the hiatus seminaris inferioris. So this was the osteomyelial complex for the maxillary sinus. Now, this is the bulla ethmoidalis. Now, bulla ethmoidalis acts as a bodyguard to the anterior ethmoidal artery. If there is no bulla ethmoidalis, you tend to injure the anterior ethmoidal artery. Whenever surgeons perform the frontal sinus surgery, they always follow intact bulla technique, right? the surgeons always follow an intact bulla technique just for one reason: to keep the anterior ethmoidal artery intact and preserved. In some cases where there is a suprabullar recess, as I just mentioned some time back, the suprabullar recess, there is an open entry to access the anterior ethmoidal artery. So in that cases, there is no protection to the anterior ethmoidal artery while performing the sinus surgery. So immediately behind the attachment of the bulla ethmoidalis to the skull base lies the anterior ethmoidal artery. Now this is the area of the bulla ethmoidalis. Just follow my cursor. This is the area of the bulla ethmoidalis, and if I am going posteriorly, you see the bulla ethmoidalis is like almost ending over here, the posterior most aspect, and see over here the very anterior aspect of the anterior ethmoidal artery just lying behind the skull base attachment of the bulla. So these are the 4 points by how you can easily identify the anterior ethmoidal artery on the CT scan as well as intraoperative. So if it be it a revision case or a massive polyposis or a massive tumor case where you are unable to identify the major structures within, just follow any one of these structures I just mentioned, any 4 of these. Now the muscular anatomy is basically obviously for the CT scan, but the ground lamella, the supraorbital cell, and the bulla ethmoidalis, I'm sure that you will always be able to find the anterior ethmoidal artery intraoperative. So just follow these 3 markers, you are bound to find the anterior ethmoidal artery. Now, what are the complications if you injure the anterior ethmoidal artery? The anterior ethmoidal artery, as you can see over here, this is the orbital part. It is beaking out through the canal called as the orbitocranial canal. If you injure the anterior ethmoidal artery over this area while surgery, or you have no idea where the artery is and accidentally end up injuring it, the anterior ethmoidal artery, having a mere thickness of just 0.8 to 0.9 mm, will retract inside the orbit like this. As you can see the anatomy of the artery here, it will start to retract within the orbit, and as you can see the orbit is bony on all sides. It cannot expand any more, so it will keep on bleeding within and it will compress the optic nerve behind. Now this is the area of the optic nerve. Now as the orbit cannot expand, it will eventually compress the optic nerve over here, and within a short span of time, say 10 to 15 minutes, the patient will definitely have blindness. So that is one major complication. And if you tend to injure the nerve or the artery, the anterior ethmoidal artery towards its medial attachment, that is the lateral lamella of cribriform, there will be a CSF leak, as it is considered that the entry of the anterior ethmoidal artery into the lateral lamella is considered to be the weakest point or the thinnest point in the entire skull base region. So if you injure the artery over here, it will definitely cause a fracture of the lateral lamella, and then the CSF will keep pouring inside. So these are the 2 complications you can land up with if you injure the anterior ethmoidal artery. So you have to be very careful about it. So this covers our entire anterior ethmoid region, anterior ethmoidal cavity region. All the important neurovascular structures we have covered. Now we will slowly move on to the posterior ethmoidal cavity. Now as we could see here, this was the attachment of the middle turbinate into the lamina papyracea, and this was the beginning of the superior turbinate. This is basically the posterior ethmoids, and here was the entry of and here is the initial most part of the posterior ethmoidal artery, this being the posterior ethmoidal artery in the posterior ethmoidal cavity. And this is the entire posterior ethmoidal cavity. As we keep on going behind, it eventually attaches to the perpendicular plate of Palatine. Okay, there's no much significance in the posterior ethmoidal cavity, except for that in certain cases the posterior most ethmoidal cell, called as the onody, that's the only one structure that is having a clinical significance for the surgeons while doing a FES surgery. The other things you should know about the transition between the anterior and the posterior ethmoids on a CT scan. Now this is where the importance of the dynamic CT scan lies in. Now see, this is the anterior ethmoidal cavity. The anterior ethmoids are very numerous and small in size. As you can see here, there are a lot of cells and they are small in size as compared to the posterior ethmoids, where you could see only few cells and which are large in size. So anterior ethmoids are small and many in number. Posterior ethmoids are large and few in number. That's the first change. See the orbit. See the orbit over here. This is the cribriform. This is the anterior ethmoidal cavity. See the orbit over here. The orbit in the anterior ethmoids is circular. It's properly circular, and as you follow it posteriorly, the moment the posterior ethmoid starts, see the orbit. It changes from circular to conical and keeps on getting conical and eventually disappears. See this? Eventually disappears. So in the anterior ethmoids, it was circular, and as soon as the posterior ethmoid starts here, once this is a posterior ethmoidal artery, so once the posterior ethmoid starts, that point the orbit starts becoming a conical cavity, and as you can see, it eventually becomes conical and then disappears. So that's the second change. Now what's the third change? As you can see here, this is the anterior ethmoidal cavity. This is a skull base, this is a medial lamella, this is a lateral lamella, this is the ethmoidal fovea, and this is the ethmoidal roof. Now, this is the anterior ethmoidal cavity. As you can see over here, it has an angulated course over here. It is at a particular angle to the skull base. The skull base area has a particular angle to the cribriform plate. This is in the anterior ethmoids. Now, as you keep on going posteriorly, as you can see, the skull base becomes more flat. Okay, see, eventually you're in the posterior ethmoids now. The entire skull base is flat. This is a huge transition where you can identify that whether you are in the anterior ethmoids or the posterior ethmoids. See, this is the importance of a dynamic CT scan, where you can easily see the motion of the skull base. See here, this is the anterior most aspect of the skull base. Now just follow the cursor. You can see if I tap the keypad, it will have a continuous motion. You can see this slant skull base becoming horizontal in origin. See, this is the most anterior aspect. As you can see this, it becomes vertical, from vertical to horizontal. See this? This is vertical skull base, and now it becomes horizontal. So that is the importance of the dynamic CT scan to study where exactly it becomes horizontal. So that was the third change. The fourth change, as you can see in the anterior most aspect, the skull base is thin. So it is more liable for a surgeon to cause an injury in the anterior skull base. As you keep on going behind, you can see this, the thickness increases, and the thickness of the posterior skull base is huge as compared to the thickness in the anterior. You see this? This is the thickness in the anterior, which is thinned out, which is pretty much thinned out. This is a skull base, a thin film of bone. This is a thin skull base, and as you go behind, it becomes very thick. See the thickness over here? The thickness of the skull base is huge over here. So as you enter from the anterior to the posterior ethmoids, it keeps becoming more and more horizontal, and it keeps on getting more and more thicker, so that the injury in the posterior ethmoidal cavity skull base is less as compared to the anterior ethmoidal cavity. That was the fourth change. Now, the most important change in the fifth point is the appearance of the sphenoid. So first was the orbital change, second was the thickness, third was the angulation, fourth was the number and the size of the cells, and the fifth one is the maxillary sinus. Now I'm in the anterior most aspect. See, this was the beginning of the maxilla over here. See, this is the anterior cranial fossa, or the anterior ethmoidal cavity. As I'm going behind, see, this is still the anterior ethmoids. See, the maxilla is conical in shape, it is triangular in shape. See, this is a triangle. The maxillary sinus is triangle in shape in the anterior ethmoids. As you go behind, See, this is the area of the ground lamella and this is the superior turbinate. So this is mostly the posterior cavity now. See this, the shape of the maxilla starts becoming oval. So as you keep on going posteriorly, it becomes oval, and then eventually disappears finally. So these were the 5 transitions where any surgeon, if you are given any scan or any particular single scan, you can identify whether you are in the anterior ethmoids or the posterior ethmoids. So these were the 5 transition points: the orbital anatomy, the maxillary anatomy, the thickness, the angulation of the slope of the skull base, and 5th, the number and size of the ethmoidal cells. So 5 points you always have to remember for the transition. Now, once you're in the posterior ethmoids, you just have to look for the onody and the superior turbinate. Now, one more thing I'd like to add over here is that I have told this in my previous videos as well. When you are stabilizing the middle turbinate through a procedure called as the microfracturing, you always have to do the microfracturing at the level of the junction of the anterior 1/3 and the posterior 1/3 over here. If you fracture the middle turbinate towards its upper attachment, see how closely it is attached to the skull base. If you fracture it over here for microfracturing, it has a high chance of a CSF leak. So always fracture in its lower 1/3 towards the junction of the anterior and the middle 1/3 to have a proper stabilization without a chance of CSF leak. Now if you're going to see the superior turbinate is attached to a much thicker skull base posteriorly. So even if you fiddle with the superior turbinate or handle it roughly, there is very less chance of a CSF leak as the skull base attachment is very thick. So there is no chance of any injury over here. So these are the very basic things a surgeon needs to know on the radiology aspect as well. Now, finally, eventually we approach to the sphenoid sinus. And the sphenoid sinus has a huge importance. Now, once we cross the posterior ethmoids over here, as you can see, now how to identify that you have entered the sphenoid from the posterior aspect? Now, many young surgeons I have seen, now I have worked in government institutes, I have worked in many other institutes as well, private, government. I have seen many young surgeons just blindly entering into sphenoid from the posterior ethmoids without even then knowing that they have entered the sphenoid sinus properly. They just blindly enter into the sphenoid through the posterior ethmoids without knowing the anatomy of the onody cell, having a huge risk for the optic nerve injury. Now, I would like to explain in very short the transition of the posterior ethmoids into the sphenoid on a CT scan basically. See, what is this you can see over here? Now, what is this over here you can see? This is the skull base, this is the brain over here, this is the entire brain. So this is the floor, this is the skull base basically. For a skull base surgeon, this is the skull base over here, entirely in continuation. See, this entirely, it is in continuation. There is no defect or any gap in between. If you keep on following it posteriorly, this is the frontal bone, this is the orbit, this is the orbital plate of the frontal bone anteriorly, this is the orbit, this is the orbital plate of the frontal bone, and this is the pterion, this is the pterion. From pterion to pterion, as you can see, the entire skull base is intact. And if you keep on going posteriorly, there will be at some point, see this, there will be a point where there is no more continuation. And eventually you will see a structure like this. Now, what is this now? Very important, remember this always. This is the lesser wing of sphenoid. Okay, this is the lesser wing of sphenoid. And if you keep on going posteriorly, you can see now the sphenoid body having the 2 sphenoid sinuses. So once you start seeing a defect like this over here, this is the lesser wing of sphenoid, and keep on following that, you will see the initiation of the sphenoid body. Within the 2 is the right sphenoid and the left sphenoid sinus with the intersphenoid sinus septa. Keep on going posteriorly, end up in the sphenoid sinus proper. So there are two important points of identifying the posterior from the sphenoid. The very first was, as I said, pterion to pterion. You have to identify this is a continuation seen. If you go posteriorly, there is no more continuation. See, this is why a dynamic CT scan is very easy to use. See, as you can see, this is the most anterior aspect, and as I'm going posteriorly, you can see now it's all gone. It was here right now some time back, and now it's gone. See, this is a lesser wing of sphenoid. Once this bone starts, assume that this entire region is of the sphenoid bone. See, you can see this entire region of sphenoid bone. Now, this scan in right of front of you is this region belongs to the entire sphenoid bone. There's no other bone in the picture right now. If I'm zooming it right now, see this entire structure is of sphenoid bone. No other bone is forming any part of the area right now. You see over this is the anterior clinoid process. This is the planum sphenoidale. This is a right sphenoid sinus, left sphenoid sinus, completely opacified with a bit of anaerobic gas shadow in here in the right sphenoid. This is the pterygoid body. This is the pterygoid body. As you can see over here, this is a pterygoid body. This is a medial pterygoid plate. This is a lateral pterygoid plate. And this is a greater wing of sphenoid. The greater wing of sphenoid. This is the choana. So this entire structure is of a sphenoid bone, basically. So as I wanted to show you that this was the first point of identifying the sphenoid sinus. The first point was definitely the pterion to pterion. If there is no continuation, that this is no continuation. The second point, now what's the second point? See, right from the anterior to the posterior ethmoids, we could see this along this structure vertical, the bony structure. See, right from the anterior most aspect, see this is the cribriform. This is the septum in the midline with little spur over here. As you keep on going posterior, 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 you can see this is the septum. It's a bony septum with a huge spur over here. Right from the palate region over here, that's the maxillary crest, up to the skull base over here. There's one single bony structure called as the nasal septum, the bony septum. As you keep on going posteriorly, you can still see the septum in place. Now, once this lesser wing of sphenoid starts, as you can see over here, this is a lesser wing of sphenoid starts. You can see this is a thickened area over here. I'll show you in the transition. See, this was the normal septum. Now look, keep an eye on the cursor over here. As I'm going posteriorly, see this, the lesser wing has started over here, and see this area of the septum now. It is becoming thicker and thicker, but not this region. This region still stays the same. This is thinned out, and look at this area now. As the lesser wing is in approach, just visualize this area. As you can see, it is getting thicker and thicker now, this area. And this thickening of the nasal septum above is no longer the nasal septum, but this is a part of the rostrum of sphenoid. So this area is now called as the rostrum of sphenoid, and it keeps getting thicker, and eventually it enters into the sphenoid, and that same thing becomes now the intersinus septa. See this? This becomes the intersinus septa, and this is a nasal septum now, and this being the sphenoid area, and this is the choana now. See, that was the area where you should understand the transition between the sphenoid and the posterior ethmoids. So 2 points. First one was the pterion to pterion, that is the appearance of lesser wing, and second one was the thickening of the upper part of nasal septum called as the sphenoid rostrum, eventually becoming the intersphenoidal sinus septa over there. So this is how you identify the sphenoid sinus. Now, why sphenoid sinus anatomy is so important on the CT scan basically. I'll explain this in like next 5 minutes, the entire sphenoid anatomy and the contents in it. As you can see, this is the anterior clinoid process, the most anterior aspect being this is a lesser wing. Now this is the anterior clinoid process. Now you can see this cup-shaped depression over here. I will just zoom it for you guys. This cup-shaped depression over here, you can see this, that's the depression that is medial to the anterior clinoid process. That's the optic nerve. That's the optic nerve. That's the right optic nerve. That's the left optic nerve coming here in between, forming the optic chiasma over here. This is the planum sphenoidale. Okay, this is the lateral sphenoid wall. This is the intersphenoidal sinus septa with both sphenoid sinus ossified. This is the pterygoid body. This entire structure is a pterygoid body, and this is a pterygoid body. This is a medial pterygoid. That's the lateral pterygoid. Now, what do you see over here? What do you see over here? This one and this two. This one and this two. What is that? Now, what are these two circular structures you can see? See this one over here, one over here, one over here, and one over here. Now, this is the right side. This inferior medial. This is the medial aspect. That's the lateral aspect. This is inferior. This is superior. So the inferior medial belongs to the Vedian canal. So Vedian is median. Okay, so this is a Vedian canal having the Vedian nerve, that is a nerve of pterygoid canal, and the superior lateral is the V2, that is the foramen rotundum having the maxillary nerve. So this is what? This is Vedian canal, inferior medial, and this is what? Foramen rotundum V2, which is superior lateral. Same thing over here, Vedian canal and the foramen rotundum having the V2 maxillary nerve. Okay, same thing. Apart from that, this is the medial pterygoid, the lateral pterygoid. This is the choana. As we all know, this is the nasopharynx, and the choana lateral wall is made up by the medial pterygoid plate. So in cases of choanal atresia, this is the medial pterygoid plate, which is having an excess extension blocking the entire choana. So this was the optic nerve. Okay, this was the optic nerve, and this area over here, this area is the cavernous sinus. On either side of the sphenoid sinus is the cavernous sinus. Okay, this is the optic nerve, and as we all know, what lies in the cavernous sinus is the internal carotid artery. So this is the internal carotid artery. This bulge you can see over here, this C-shaped bulge over here. This is a bulge over here. That's the bulge of the internal carotid artery. That is the cavernous part of the internal carotid artery. So the internal carotid artery has 7 parts, which I'll explain it to you in future videos specifically for the carotid artery. So just for now, remember the carotid artery has 7 parts, right from its origin in the neck up to the skull base and into the brain. So this part you see over here of the carotid artery is the cavernous part of the carotid artery, which has a paraclival part and a parasellar part. Okay, so these two parts come over here, that is the cavernous part, representing the genu, the anterior genu of the carotid artery. So this was the sphenoid sinus for you in general. If you keep on going posteriorly, you can see the medial pterygoid vanishing away. It's disappearing because we are going way posterior right now. And if you keep on going posteriorly, you can see a defect in the bone sometime over here. See this? This is a defect you can see in the bone right here. This is nothing but the greater wing of sphenoid, and this defect you can see is nothing but a canal. This is a foramen. This is known as the foramen ovale. This area of gap you can see over here is the area of the foramen ovale, which, as we all know, contains the mandibular nerve, the V3. So if you go on further behind, you can see the temporal bone coming into picture with the mastoid air cells, and this is the temporomandibular joint as you keep on going behind, and that's the posterior most aspect of the middle cranial fossa. That's the vertebra coming into picture. That's the vertebra, the atlas and the axis, and the foramen. You can see this foramen magnum into picture. The foramen magnum, the biggest opening for the spinal cord, is over here in this region. The foramen magnum, this is the atlas and the axis vertebra. You can see this, the odontoid process of the vertebra coming into picture, and this is very important for the skull base surgeons for having the anatomy. This is the semicircular canals. So this is the posterior most aspect of the temporal bone. This is the auricle coming into picture. This is the external auditory canal. Okay, so yeah, so this was the basic anatomy for the FES skull base surgeon. Now, if at all, if many surgeons also miss anatomy, which we just left out, was the area of the orbital apex, the area of the sphenopalatine canal, and the area of the inferior orbital fissure. Now, just in 2 minutes, I'll explain the exact location of these various structures. Now, as you could see, this was the orbit. Just follow the orbit. This was the orbit. Okay, if you go to the posterior most aspect, this is the orbital apex area. As you can see, this is the orbital apex. Now, the orbital apex in relation to the sphenoid sinus. Okay, this was the beginning of the sphenoid sinus proper, and anterior to it, you can see this area of the orbital apex. This is the orbital apex. See, this is the area of the orbital apex. And as you go behind, you can see the sphenoid sinus starting, and as we all know, sphenoid sinus is surrounded by the cavernous sinus on either side. So the moment the sphenoid sinus starts, assume that it's the carotid artery over there, and that's the cavernous sinus over there. So what is cavernous sinus? Now, what is orbital apex? Orbital apex is nothing but just the area where the superior orbital fissure is. And what is superior orbital fissure? Superior orbital fissure is nothing but the anterior continuation of the cavernous sinus. So you can see the cavernous sinus posteriorly, anteriorly is the superior orbital fissure and the orbital apex. So the orbital apex syndrome and the superior orbital fissure syndrome is all in relation to the cavernous sinus. So this was the area of the orbital apex, being the area of the superior orbital fissure, and just posteriorly you can see the sphenoid sinus and the cavernous sinus over here. So cavernous sinus is posterior, the orbital apex is anterior to it. This is the orbital apex, this is the cavernous sinus area, and this is the orbital apex area with the superior orbital fissure in view. So that was the superior orbital fissure, the orbital apex, and the cavernous sinus, roughly the cavernous sinus area. The second thing is the inferior orbital fissure. Now just keep on following the orbit. This is the orbit. Keep on following the orbit. You see this inferior gap over here, this bony area, the defect in the bony area. This is the inferior orbital fissure. Just keep on following it. This is the inferior orbital fissure. Okay, that's the inferior orbital fissure. So just in relation to the inferior orbital fissure, there is the area of the sphenopalatine canal. You see this area? Now keep on following the maxilla. This is the maxillary sinus. That's the maxillary sinus. Keep on following it up to the most posterior aspect of the maxillary sinus, and see this perpendicular plate of the palatine bone. At the most posterior aspect, you will see an area of bony defect in the perpendicular plate of the palatine bone. See this area over here? This is the area of the bony defect of the perpendicular plate of the palatine bone. And see this area? This is the area of the sphenopalatine canal. See this area? That's a bony defect and is in close relation to the inferior orbital fissure. That's the sphenopalatine canal, through which there will be the sphenopalatine artery, the nasopalatine nerve. Okay, so that's the sphenopalatine artery proper, and this is the pterygopalatine region, pterygopalatine fossa, and here this is the infratemporal fossa. So this is how you identify the area of the pterygopalatine fossa and the infratemporal fossa. So you follow the maxilla, you reach the posterior wall of the maxilla, and behind the maxilla is what? The pterygopalatine fossa. And pterygopalatine fossa connects to the infratemporal fossa through the pterygomaxillary fissure. And what is behind the pterygopalatine fossa? Now this is the pterygopalatine fossa. What is behind that is the pterygoid bone. This is the pterygoid bone. See, this is a pterygoid bone with the medial pterygoid and the lateral pterygoid plate. So they all lie in one single axis. So all this you can study on the CT scan and have a better understanding. So this is the importance of the dynamic CT scan, where you can view the entire structures anteriorly, posteriorly, to and fro without any defect in between. So this was the entire anatomical coverage in this region. So suppose we saw the perpendicular plate of the palatine bone over here, and through which we could see the area of the inferior sphenopalatine canal. This was the area of the sphenopalatine canal. See, this is a sphenoid bone, that's the lesser wing. This is a sphenoid bone. This is a palatine bone. So the name is sphenopalatine canal in between the two. Now, as we know, the perpendicular plate of the palatine, okay, the perpendicular plate of the palatine has two processes. One vertical process which is going towards the orbit over here, that's the orbit apex area. This is one vertical process called as the orbital process, and one horizontal process towards the sphenoid going posteriorly, like here, like this. See this bone? Can you see this bone over here? That is the sphenoidal process of the perpendicular plate of the palatine, clearly visible over here. Okay, see, you can see over here, that's the sphenoidal process. So vertical orbital process and a horizontal sphenoidal process. So between these two processes there is a notch formed, and this notch is covered by the sphenoidal body above, so forming a proper canal, and through this canal there is the entry of the sphenopalatine. This is the canal, this is the entry point for the sphenopalatine artery. And the sphenopalatine artery, once it enters the nasal cavity, just after the canal, it gives off a posterior septal branch and a lateral branch and a branch to the inferior turbinate over here. So the posterior septal branch becomes the basis for the Haddard flap, which we harvest. So this is all about the inferior orbital fissure, the sphenopalatine canal. So in cases of a juvenile nasopharyngeal angiofibroma, GNA, this is a main feeding vessel in this region, and it can spread to the orbit through the inferior orbital fissure, into the infratemporal fossa, into the nasal cavity, into the orbit, everywhere. So this is basically how you should identify the anatomy on a CT scan basically. So the bone window, the soft window, everything you can study on this software, so to have a complete understanding of the anatomy of the sinuses. So I hope this video was of real use to the young surgeons and many surgeons out there who are new for the sinus surgery area, and those who are not well acquainted with the CT scan reading, because many surgeons rely on the radiologist for the reporting and they themselves are not confident about the anatomy. So I hope this video helped you a lot, and I'll be posting videos, many more videos on my surgeries and the CT scans and the MRI scans of various different tumors and pathologies in the nasal sinus and the skull base regions. So keep subscribing and keep learning. Thank you so much. See you soon.